Okay, let's move on to the next part of this series, which is the advanced airway, or at least the part of the advanced airway management that we call endotracheal intubation, because a lot of the advanced airway stuff, at least surgical airway, FONA, and what is oftentimes considered advanced, an LMA, we've already gone through that. So this part will only focus on the endotracheal intubation and how to do an RSI, so that we know what our anesthesiology colleagues are doing and how we can help them in this sequence of events that has to go on. And it's also just good to know this sequence so that we kind of know how much cognitive loaded our colleagues usually are during this time, especially in a tight situation. And how we can help them out with this process so that it goes as good as it can for the patient. And of course, if that time and situation may not arrive, that we ourselves know how to do this if we need to. Okay, so Eric Chappell is a YouTuber that I mentioned in the beginning of this lecture. And he's done this really great video on the overview of what kind of methods you can use to intubate a patient. So I encourage you to look at his channel. I have borrowed one of his slides here, and just to show you an overview of the things that you can do and what kind of approaches you can take to intubation. So first of all, you have your traditional intubation method. This is where you pre-oxygenate the patient. Then you will usually do what Eric calls a sedative soup. You will do some sedation and usually give you induction agents, and then they'll fall asleep. This, I guess, the highlight of this traditional method is that it's usually a time where it's a situation where you have time and where the aspiration risk is lower. Those are some of the hallmarks of this situation, and therefore you can afford to use a little bit more time when pushing the drugs. You can do a more clean sedation and induction instead of what we see in the RSI, which I'll come to now. Because in the RSI, or rapid sequence induction, or rapid sequence intubation, depending on how you like your terminology, there is an aspiration risk, or we assume that there always is an aspiration risk. The patient isn't fasted, and usually they're in a bad way. Traditionally, this has been operation theater stuff for patients like pregnant patients and patients with ileus, small bowel obstruction, and so on, where there's a high aspiration risk, even though they might be fasted. But it's not new, but this has then moved into the emergency department as the method of choice for most patients when you need to intubate them quickly. The hallmark of this method, or some of the hallmarks of this method, is that the drugs are giving at the same time, and you're taking all the precautions that you can so that the patient isn't aspirating, so the time where they are without a tube is as low as possible. Also, because of critical hypoxemia, this is a good way to go. Then we go to what you call DSI, a delayed sequence induction or intubation. This is a term coined by Scott Weingart, and he usually talks about the DSI being it's like a procedural sedation, where you're sedating the patient so that you can pre-oxygenate the patient. So the thing is, it's usually used when you have a very agitated patient. You can't really get to pre-oxygenate them because they're so agitated, and you need to do that. So what you do is that you sedate them, usually with ketamine, and just a small sedative dose, not an induction dose, and then things are calm, and the blood pressure will usually stay where it is because it's a low dose. And then you can pre-oxygenate them. So it's a procedural sedation where the procedure is the oxygenation part, the pre-oxygenation part. And then sometimes, or oftentimes, according to its author or its creator, Scott Weingart, oftentimes there's no need for anything else. Oftentimes you don't need to go on with the intubation now that you can oxygenate the patient and you can actually do what you need. If they still are in a bad way and they still need to be intubated, then you can just push the same drug that you had here a bit further, or you can do what you call ketofol. You can use a combination of ketamine and propofol, theoretically getting the benefits of both drugs. But I guess there are some studies that might suggest otherwise. You can check out St. Emlyn's on that evidence-based bite. Okay, so this is usually for agitation or a situation where you need to, where you can't even get to start your oxygenation. Then you have the awake intubation. This is usually something that is, if our assessment of the airway is that it's really high risk, this might be epiglottitis, this might be inhalation injuries, this might be a cancer that is slowly progressing and now is occluding an airway in the upper airway. This is where you want to use or want to try to use an awake intubation method, and this is something that we should never do. And as I alluded to in the beginning of this lecture, we should use one method, maybe also know the delayed sequence induction, and then just stick with those. The awake is a good thing to know about, though, that this is an opportunity for especially epiglottitis patients, and the key thing with the awake intubation is that you're going usually through the nose with a flexible fibroscopy, and then you're loading that fibroscopy tube or the bronchoscope tube, bronchoscopy optic. You're loading that with a tube so that you go through the nose, and you can then you can push the tube over through the nose and into the airway. And as you might imagine, the key thing in this awake intubation method is that you keep the patient extremely well locally anesthetized. So you need to really have a good aerosolizer to get to overdose almost your lidocaine or xylocaine treatment of their oropharynx, nasopharynx, and nose and throat. And sometimes you can even go in through the cricothyroid membrane with a bit of lidocaine as well, to make them cough all the way up through their airway. There are different methods for this, but it's like key thing is, as Dr. Kovac usually say, that it's really all about the topicalization. And there's even videos where people are doing them to themselves when they're good and when they're well topicalized. So then you also need a calm environment. And what you usually do is when you have the tube in, when the patient, then you really need a team that is skillful here, because they will be awake when the tube is being put in and is being cuffed only when the team has a end-tidal CO2 measurement. You can push your induction drugs, because then you have a safe airway. So this is really something where you need to have a really, really tight plan and a good, well-oiled team. And usually it's a combination of anesthesiologists, ENT specialists, and so on. But Dr. Kovac encouraged us that emergency physicians could do this, but I doubt that this is anything within our territory, especially in Scandinavia. Okay. So, and if you want to hear Kovac talk about this, then try to check out the EM Cases website with, especially on the burn victim science, or the burn victim episode. If you want to see one of these being done, and how it's done step by step, then please check out the Arrest, the YouTube channel from Lund in Sweden. They have this great video about this. You can also check out Preperation YouTube channel. If you want to check out RSI, then the theory behind RSI you can find here, among other here, on the ICU Advantage homepage. You can also find pre-hospital inductions, RSIs, and you can find other like step-by-step RSIs here on this YouTube channel. I would encourage you, no matter whether you are interested in this topic or not, to check out John Hines' lectures, because he's just such a great lecturer, but also because it's entertaining and it's really amazing. These lectures called Cases from the Races are amazing, and goes into the entire problem with pre-hospital RSIs. Okay, for DSIs, I would suggest checking out the creator himself, his homepage, MCRIT, and because it's almost a procedural sedation kind of framework, I would encourage you to check out this often quoted Ruben Strayer EM updates video trilogy about PSAs. For the traditional method, in operation theaters, you can check out again, Interest has this great video on this. This is probably the best, and it's English, so this is probably the best video I've seen on this. And there's a lot of other videos on the internet. These are just some suggestions, and you can check out the link page in the beginning of this lecture for more. Okay, so now I want to go through step by step when we have decided that we need to do an RSI on this patient, or do a intubation. We need to intubate this patient. We've done the risk assessment, and we are at the point where we need to intubate the patient now. Then we have to go through some steps in order for this to happen. Some places have checklists for this, especially for the preparation phase, and I'll show you one of these checklists. But these are usually in some way. These are the steps that you'll go through. There are some variations in different setups, but these are usually the steps. If you want to have a read about how to go through these from another creator, you can check out Life in the Fast Lane's RSI blog. Okay. So first of all, you need to consider, is RSI the best approach here? Well, that depends. We just saw all the other kinds of methods that we could use. Maybe awake is an option here. Maybe this patient needs to be sedated a bit first before we can actually pre-oxygenate. And so that's always important to consider. Do we really need to intubate the patient right now? Or could we manage the airway in another way? Do we have to do it here and now, here in the emergency department? Should we do it in the ICU or the operation theater where there is more stuff if it goes to the south, and so on. So it's always nice to ponder that question. Yeah, here are the methods, and here's the video from Eric Chappell. But so these are some of the questions that we want to ask in the beginning here, and we already gone through these, so I'll just leave it with that. Okay, then the next step here is to do the risk assessment of this airway, and this is where this thing comes in. Of course, we've also done it just so that we know that we have to go into this mode. We've already thought about this, but here we can do more analytically and see, okay, what are the risks here?
And remember the anatomical risks, the physiological risks, and the psychological risks all play in. Should we, and especially the psychological here, should we do it in theater? Should we do it other places? The physiological risks, what kind of medication should we use? We'll come to that later here. And the anatomical risks, should we use a video laryngoscopy? If it's a difficult airway, do we need expertise here? Do we have that expertise? Is there time for that expertise to arrive? Do we have any other options? So on and so forth. These are the thoughts that needs to go through our head at this point. And then when we have made some kind of decision, then we'll have to brief the team on what we're going to do. So the first plan is we are going to do a endotracheal intubation. Right now we'll need a few minutes to prepare, especially to pre-oxygenate the patient and then prepare the stuff that we need. So we will need 3 or 4 minutes for that. In the meantime, we will try to resuscitate the patient as best as we can. That's plan A. If this doesn't work, then we'll try again. Then we'll try to use back valve masking with this patient or LMA. There's always the opportunity in some situations just to, especially if you're using propofol, just to let the induction agent go out while you're using back valve masking. But that is, in an emergency department case, usually not something that is achievable. So plan A, endotracheal intubation, and you explain which kind of drugs you want to use and how and so on. And we'll get to that later. And then if that doesn't work, we'll go to back valve masking with this patient, and then if that doesn't work, we'll try LMA. And if that doesn't work, I want the cricothyroidectomy kit at the bedside. Is everyone okay with that? It's really important to do a psychological safety encouragement. So like, is everyone okay with that? Open question, so that everyone can jump in. You might even go as far as Chris Hicks usually say, like, what am I missing here? What am I doing wrong? Because that that creates what you would call a vulnerability loop, saying like, I am not flawless. Please come in and help if you see something that I don't. All right, so this is a bit of human factors. I've made a video about that as well, but these are really important topics as well, especially with the vortex model and in these situations. Okay, but we've planned now, and yeah, one of the things that I haven't talked about is we always need to think about, well, what if they go into cardiac arrest? Should we do anything? Or should we even do this entire operation now? Should we even do this? Or should we just say, well, this is it. We can't do anything curative anymore. We have to go to another mode of delivering care, which would be palliative and like comfort care. So, well, this also goes into your decision making when you have these patients. Okay, then comes the positioning of the patient, and you want to position the patient so that there is ideal. You have an ideal situation for intubation, and we talked about this ramping position for most patients is a good way to get that. Especially if they're obese. If they're not obese, you maybe don't need to ramp them that much, but at least you have to do the your flex-tension. Sometimes if your patient is spined, like cervical spinal immobilization, you sometimes can move the entire bed up as well if the blood pressure can handle it and so on. It's always a balance of priorities. So, all right. There's one thing about the position. We talked about the position of the patient, but we should also talk about the position of the doctor. Usually when you want to go into the mouth with your laryngoscope, so that either you're sitting or you're standing. Any heart procedure, you always need to make sure you're standing or sitting in a comfortable position, because otherwise that like mind-body complex will, if you're stressed in the body, then you'll probably be stressed in your mind, and this is a loop, so it'll just go on and on. So you can save a lot by just being comfortable, and it goes for every kind of procedure. Be as comfortable as you can, Of course, in pre-hospital settings, that's often not achievable, but in a hospital setting, that is. And so you want to stand up, and you want to rest your arm, usually so that you can rest your arm here while intubating. You want to have the height of the bed so that you don't have to bend over, because it's really important when you're going to intubate the patient that you stand up instead of going into the mouth of the patient, because you will have a better view if you're standing up. So that usually when you try to intubate the patient, you have there's a reflex almost that people will look into the mouth and like try to crouch into the mouth of the patient to see better, but actually you're actually seeing better because of the line of sight. You're seeing better when you're standing up straight. So stand up straight if you have a difficulty seeing where you are. Okay. Then we come to the pre-oxygenation part, and I've just touched on this earlier a little bit. The thing that we are trying to achieve during pre-oxygenation is that we want the oxygenation to go up, and we want the denitrogenation to go down, or the nitrogen level to go down, so that there are more space for oxygen. We achieve the oxygenation part just by having a mask on, but the denitrogenation part, that we will only achieve if we have a tight seal. So that's important. When you pre-oxygenate, we have to have a tight fitting mask. We can do it with a back valve mask with a double hand grip optimally. You can do it with a NIV, like a tight mask. It's important for the tightness because you have to have a closed system for this nitrogen to be washed out. And if it only takes maybe 1 or 2 breaths without this tight system for the nitrogen to go back up, and then you've spoiled the last couple of minutes where you tried to pre-oxygenate the patient. Of course, you will still have oxygenation, but in tight spots, in difficult situations, it is really important to do decent pre-oxygenation, right? So you want this to be optimal, because then you have more time to do what you need to do. So another thing with this curve that is important is when we have time here on the x-axis. So the time at which this is happening, where we have probably maximal, or where the return of like the law of diminishing returns comes to an end, it comes to a halt almost, is around the 3-minute mark. So that's why oftentimes it's decided that we should pre-oxygenate patients for 3 minutes. Or sometimes they say 8 breaths if the patient is awake. But I'm no expert in this area, so I won't say any more than that. I'm just saying that some guidelines suggest a bit more, some guidelines suggest a bit less. It really depends on. But 3 minutes, 8 breaths, you won't go wrong with that if you have an exam question. All right. And then after the pre-oxygenation, we of course do the induction, and I just wanted to show you what happens then, and that's why this is so important. Because then in the apneic period, when you induce the patient, they don't breathe. I know that seems obvious, but I mean, there's a lot of stuff happening, and there's a lot of stuff to keep an eye on, and it's not easy always to know, oh well, the patient isn't breathing. That is what happens when you have the apneic period. When you push the drugs, you own the airway. As opposed to a sedation, where in a sedation the patient should be breathing by themselves, but I guess there's a gray area between sedation and induction, where they are, if you pain stimulate them, then they probably will breathe, but not as much. So yeah, there's a gray area there. But for the induction, you will not breathe. That's the purpose of it. And there are and when you don't breathe, then you will of course deoxygenate, and and we talked about how fast you deoxygenate depends on whether you're a child, whether you are obese, whether you are in a critical situation with a high metabolism, and so on and so forth. So certain populations deoxygenate much faster than other populations, and in general, critical patients, children, obese, and pregnant are some of the ones that really deoxygenate faster. That's where you want to have an optimal pre-oxygenation. Some of the critical patients can't go up to 100% in saturation. That's not possible because of the pathology. So you just have to do as good as you can get. And I just wanted to remind you, this is another way of seeing this, where you have your a good pre-oxygenation, and you have this long period of time to critical desaturation, depending on the situation, of course, and individual patient factors. But you get this safety margin, and you want this safety margin to be as large as possible. Yeah. So as we said, 3 minutes or 8 full standard breaths, tight seal, and the goal is to increase the oxygen reserve so that the critical, like the desaturation below maybe. No one knows how low is dangerous, but probably like as you saw in the oxygen curve that I showed in the beginning, below 90 is usually a rule of thumb, where it is really going south. So even before going below 90, you should consider doing something like maybe below 93, 94, if they come from 100%. Depending on the situation, of course. If they were never on 100%, then you have to modify that. There are some extra tips here, and one of the really hot things that are going on is what you call apneic oxygenation. So in the apneic period, you could oxygenate the patient. So when you've induced the patient, so you have pre-oxygenated the patient, you have induced with drugs, you own the airway now, you breathe for the patient. Traditionally, you don't want to bag them because there's a risk of aspiration. The evidence on that is being turned around now. So you can, if there's a critical patient and there's really a need for bagging, then some of the societies do not recommend against bagging, gently bagging, but only gently bagging. But another way of doing that would be to the apneic oxygenation, where you have either a nasal prong in the patient's nose with 15 liters of air, or what you could do what has been dubbed the Thrive method, where you do a optiflow or high flow in the nose. And there are some really promising studies, both in emergency medicine and in operating theaters, I'm told, where you can actually keep the apneic period or the time to critical deoxygenation for like tens of minutes, at least in the operation theater, with this method. So it's and maybe not as long as in the emergency department yet, that I don't know, but this is definitely something where we can keep the patient from desaturation if we use this, and I think in the future we might see much more of this during RSIs in the emergency department with high flow in the apneic patient and in the apneic period. But until that time comes, at least we always need to have a nasal prong in the patient's nose with 15 liters or as high as it goes. So that they are getting some oxygen during the apneic period. And this is also Rich Levitan and Scott Weingart who's pushed the evidence on this area, for what I know. Then we can also use CPAP, and CPAP, I guess, does a couple of things. But check out Kovac's videos for the lung video where he uses CPAP. It's a very good visual of why this is important. But in a nutshell, CPAP will keep the lungs expanded. Your pre-oxygenation will and denitrogenization of the lungs will make it easier for the lungs to collapse. Therefore, it's a good idea to give a little bit of PEEP. You can attach that to a back valve mask. You can do it with NIV as well, as we saw in the earlier lecture, and especially in the obese patient, this is really important to do. But you can do it in all patients. Of course, there is a theoretical higher risk of the patient aspirating because you're putting more pressure on the esophagus. But as far as I'm concerned, this is mainly theoretical, I think, just like the evidence on ventilation is getting turned a bit around right now. So these are some extra tips during the pre-oxygenation phase to increase your safety margin the most. I just wanted to show you this data from, there's a couple of studies, but this is a study from, this is a meta-analysis of the Thrive method here. And you can see, like, with a normal face mask, you can see that each of these dots is a patient. And you can see this is a line between, I think, below 92% of oxygen, and here you can see that with a normal method, a few patients, even though this is a stable environment, this is not from the emergency department, but this is an operations theater, you can see a few patients do actually go below saturation, and they don't with the Thrive method. This is keep in mind, this is a small sample, very few patients, and it's also not a patient-oriented outcome. We don't know, it's a surrogate outcome, and we don't know how this affects patients and how low it should go. But there's a good theoretical mechanical argument of this should not go below a certain amount, and what that certain amount is up for debate. But I think all can agree on these outliers below maybe 85, 70. That is a place you don't want to be. Okay, then we come to your preparation phase, because the preparation phase is something that is really, really important, and this is where we might be able to help our colleagues in anesthesiology as well. So in the preparation phase, you want to make sure that the patient has an IV or an IO access, preferably two, that are working. You want to have good monitoring of the patient. You want to draw up the medication and label them appropriately so that you in the bind know what to give. You want to have your equipment ready as well, and the equipment has to be tested so that, well, the cuff didn't work is not a problem when it's not a thing that you find out when the tube is in the airway. It is something that you find out before. All right. Also, you want to check up sizes. Sizes is a huge cognitive load here. So oftentimes there are apps for size for sizes, and I have a slide in a little while here about sizes of tubes and so on. I can really encourage everyone to download the 10 kroner Copy app, COPE, for the which is also in English, but otherwise it's in Danish, and it's really amazing, and for children, doses and sizes, and not just for this but in general. And also the Danish version has a long list of emergency medicine and what to do in emergencies, and it's weight based, so you kind of roll the dial to check the weight of this child that you have in front of you, and all the medications come out that you need. We should have one for adults of these. Is so amazing. All right, so as I promised, I wanted to show you how these checklists can look. Some of these checklists are just written like this one, but I love these dump kits because they are visual, and in a situation like this you need visual cues. And here you can see you put all of this map out on a table, and then you have to, well, you need a BVM, you need some tubes, you need and you have two of them. You have a size above and a size below usually. Here there's only shown two, and then you put out all your stuff. You have your plan A, your plan B. There's lots of these, and they look a bit different. But this is from I think from Broomdog's homepage, but this is a great thing. Like they're called dump kits. You just dump everything on that, and that's a very good way of cognitive deloading a stressful situation. Yeah. Okay. And then I think we have already talked about these things, but what you do need also is an assistant that is ready and skilled. Being an assistant for the one handling the airway is really, really tough, because you have to before they know what they need, you should be able to anticipate this and actually get that for them, so that when they need it, they'll get it. So, like, nurses are amazing at this, and you need to reach. You need to give the equipment when the doctor needs it in the right way, so that they don't get the laryngoscope in the right hand. They need it in the left hand, of course, so that they don't get the tube upside down, but they get it so that they don't have to take their eyes off the screen when they're getting it. So these are parts of being a good assistant for the doctor during the airway. And this is a skill, just as leadership is a skill. The fellowship is a really important skill, and we need to know both also as emergency physicians. Okay, so I promised you a size chart. Here it is, and some other figures just to remember. So suction, as I told you, is around, usually we say 25 kilopascals, and you can calculate that for millimeters of mercury as well. I can't remember that, but here in Sweden we use 25 kPas. The tube sizing, there's a lot of variation. These are just rules of thumb. Women 7, men 8, and some would say like a bit like 0.5 above or below for each of them. When you place the tube, there's I'll show you in a little while the black markers. The black markers on the tube need to be between the airway, and to make sure that they're in the right place, you can also calculate how long. There's like some markings on the tube, where you can see how far down it is. And there is a calculation rule as well. That is the height of the patient divided by 10 plus 5. So 190 centimeter long patient divided by 5, that's 19, plus 5, that's 24. So at the teeth, when you intubate with the airway markings between the airways, then it's in the right place, then the reading on the teeth should be 24 centimeters. This is, of course, a rule of thumb and not a accurate science, but it's just to know that, okay, if you're at 18, then probably you should try to get it a bit further down, then it's probably moved up. Or if you're at much more than 24, then probably, then you might have done a bronchial intubation. And why is this important? Well, of course, if you have end-tidal CO2, then it's all right to then you know you are in the airway, but it's not always obvious in a critical situation whether you have done whether the tube has loosened, or whether you've done a bronchial intubation, because the only way to know that is usually by either point-of-care ultrasound or X-ray or listening to the chest. But all of these methods are flawed in their own way. We want as many data points for this to be as safe as possible. So that's why it's a good thing to know that you have to look at the teeth marking, how far down it is. Of course, this is different when you have when you go into other holes, like if you do a phona, you don't have to go 24 centimeters into the trachea. Then there's also the shape of your guide and the tube is different depending on what kind of laryngoscope you're using as well. If you're using a hyperanculated laryngoscope, you need to have a special stylet. But most times the best shape is what you call straight to cuff. So at the cuff, the tubing is straight, and then you'll just bend it a little bit, 25-30 degrees at the cuff, making it a hockey stick or straight to cuff. So that it goes easy into the airway. If you use a bushie, that's another thing. Then you don't angulate it in the same way. Then you load the bushie. It's important though when you're doing this that the bushie is the plastic leading, not the stylet leading. With the bushie, you just push it into the airway, so that's no problem. But if it's a stylet, and if it's a sharp stylet, as with the hyperanculated plate, it's important that the stylet is not leading. It should be just tucked inside the tube when you're going down. These are some of the preparation stuff. That's why I'm going into details here. The LMAs, or the suprachoroidal airways, should have these sizings. A standard size is usually a 4. So you have, and if you're a small person, then 3, and if it's a bigger person, then it's a 5. But 4 is the one you probably want to remember. BVM, the size of those should be enough to cover the edges of the mouth just, but not cover the eyes. And as I said with children, please download the Copy app. It's cheap and it's really high quality, made by people in the Rigshospitalet in Denmark. Again, I don't get any money for promoting this. I just think good things should be promoted like that, and that is one of the best apps I've ever seen. Here I just wanted to show you these black markings. So on most tubes there are black markings, 2 black markings, so the vocal cord should be in between these 2. And you need to make sure when you're doing the intubation that you actually see the vocal cords all the way and until it's cuffed. And don't take your eyes off them before it's cuffed. In some tubes, certain manufacturers only have 1 black line, and if there's only 1 black line, then it means that it has to be on the vocal cord. And here you have the centimeter markings. Here you have the cuff, and here's you want to check that this cuff is actually being blown up. How much you want to cuff with is different. Usually it's like 8 to 10 milliliters of air, but I've actually not seen anything specific on how much to cuff with. I guess it depends. Please leave a comment if you know. Okay, this bit is important, and sometimes you will lose it by because this is like the converter to back valve masks. Sometimes the back valve mask will, when you put a back valve mask on there, it will and you take the back valve mask away, then this portion will get stuck in the back valve mask and released from this, and then you can't find it. So it's important to don't lose this. Also, when you do what you call jet ventilation, this is a piece of equipment that we actually use to make a jet ventilation device. Okay. Here we also have the laryngoscope, and you also want to test the laryngoscope that it has a light on. This is a direct laryngoscope, an old classical, not video laryngoscope. It has a C plate, Macintosh plate. So like the C in Macintosh is there's a mnemonic where there's 2 plates. There's Miller plate, which is LL. Miller plate is straight, and you have your C plate, which is Macintosh C. And then you have your D plates, or some manufacturers call them D plates, the hyperangulated plates. These are like the 3 plates that you should know. There are probably some others, but these are the main ones. And then you have your sizes. Usually it's a size 3 that you want to use, but some people like a bigger one, size 4 for adults. And the Vortex Model YouTube page has a great video on the mechanics of why you probably want a smaller blade if you can, because then there's a smaller weight arm on the blade. Check that out if you want. Okay, and here we have the blades again. So the hyperangulated, the Macintosh C-shaped Macintosh, and the Miller blade, which is straight L, straight as an L. And you have, for each blade, you have a different type. You have direct laryngoscopy, and then you have your video laryngoscopy. And the video laryngoscopy has what you call the normal blades, and then you have the hyperangulated blades. And with the hyperangulated blades, these blades, they fit the airway just perfectly. So all the technique that it takes with these, you don't really need with this one, not as much as, and even in like it's almost idiot-proof to use those. There are certain situations where you cannot use them, and but in most situations you can. And for emergency physicians, this is really, if you're an emergency physician where you need to intubate, then this would usually be the choice if you have that. Okay, but otherwise you'll do the Macintosh. Miller is usually only used with children, and the technique is a bit different, where you want to be on the epiglottis, where with these you're trying to hit the vallecula. Okay. Okay, now on to medication. These are we're going into like preparation of medication and what kind of choices for medication, induction agents, and so on you want to use. This is a really important topic. There's a lot of opinions here. There's a lot of evidence as well. And a lot of the evidence comes from operation theorists mainly, not as much from the emergency department. And the FOMED community have huge discussions on this. And Scott Warrington and Ruben Strayer have talked a lot about dosing and how you should dose these things, especially in a HOP killer patient where they're metabolically challenged. So I have my suggestions. I try to base them in the literature on what to do, but please, if you're going to do these things, then please use the medication charts in your place and ask for why your anesthesiologist is doing as they are. But one of the main things are, as I mentioned earlier, like the dosing is probably more important than the agent themselves, induction agent themselves, and you really need to think about how you're dosing it and how you're administering it, whether you're doing it incrementally or you're doing it at full dose. And there's risks with both, and we'll try to go through these in a bit more systematic way. Okay, so in general, when you do the induction, you have usually three kinds of drugs. You have your induction agent, and because you have an induction agent, that will for everything besides ketamine, like that will shut down the patient's awareness, and then you can discuss how low they have to be in sedation or in induction. That's a spectrum, and you can induce patients until they can't breathe at all, or their organs shut down sometimes as well. But that are huge doses usually. So this is a spectrum all the way down to death. But we induce the patients, and then you want to relax the patients as well, mainly because this actually makes you use less induction agent. You want to use as little induction agent as possible, because then there won't be detrimental problems or side effects, or we will diminish those as well. So we want to use induction sparing agents, so to speak, and muscle relaxants are one of those. There's also a lot of other reasons to use muscle relaxants, but that's one of them. It's easier to intubate with a totally atonic airway. Important with muscle relaxants is that when you push that, then they will stay there for at least 30 minutes, depending on what you use, 15-30 minutes, and sometimes longer if you use rocuronium. So sometimes people are afraid of using it, muscle relaxants, because then it's point of no return. But the thing is, it's point of no return usually, nevertheless, in these kind of patients. In the emergency department, you can't just make the patient wake up. You need to manage the airway. That's why you've gotten to this point. So this is a different thing in theater, I guess. But just to talk, so I just wanted to discuss this topic where people don't give muscle relaxants usually because of the fear that there is a point of no return. For some of the induction agents that are not painkillers, you need to give additional painkillers also to reduce the dose of induction agents, and of course keeping it comfortable for the patients so that you don't increase in pulse and you don't get vital signs that are problematic. Then outside of the induction, sometimes because of the induction agents, you need rescue drugs because of the side effects or the effects of using induction agents, usually hypotension. But it might also be other things where you need rescue drugs. And in order to not use too many rescue drugs, you need to use premedication sometimes. You need to before things happen. Rescue drugs is usually what you don't want to go to. You want to pre-medicate the patient and resuscitate before you intubate the patient, so that you won't get into too much trouble when you're using as low induction agent as possible in the situation. I'll just give you some suggestions. Usually for us in emergency medicine, you will only need to know propofol and ketamine. S-ketamine is a variant of ketamine that has the same effects and the same side effects and so on, but it's double potency, so it's half the dose. Then you have muscle relaxants. There's only two, those rocuronium and succinylmethonium, and I'll go into the differences in a little while. Then you have painkillers. Usually that's some kind of morphine. With ketamine, you don't need the painkiller because ketamine is a painkiller as well. And that's usually fentanyl, or probably more often alfentanil. Your rescue drugs is usually for propofol sedations is phenylephrine, because it's all alpha. It vasoconstricts where the propofol vasodilates. You might need more general vasopressors if the patient is septic and the adrenergic load, or the adrenergic, the patient is becoming hypotensive because of they're losing their adrenaline spike. So that's where you might want to give vasopressors, and you might want to give push dose adrenaline, or you might want to give norepinephrine, depending on the situation and so on. Sometimes they can become bradycardic. That's why atropine is usually used. And sometimes with ketamine, they can become anxiolytic if you don't want to, if you're not inducing them with a full dose, but maybe incremental doses, then sometimes anxiolytics can be used. But in general, in an RSI situation, you just give more ketamine usually. But it depends how shallow you want them. And if you are afraid of giving too much ketamine, then you can use anxiolytics if they end up in an uncomfortable psychological situation. Premedication is somewhat the same. It's all resuscitation before you intubate. Antiemetics, especially with ketamine, but also with propofol, might be important because there's a large amount of people who vomit with these induction agents. Anxiolytics is also with ketamine. I don't think for premedication that is being used too much. It depends on the tradition in the department you're working in, and of course resuscitate before you intubate, noradrenaline or fluid and blood. Let's go into the induction agents here. In general, with the induction agents, there's a few just pointers that I picked up and I wanted to share. First of all, to reduce the drug dose, besides using muscle relaxants and with propofol using painkillers, if you want to reduce the drug dose needed, then you can also keep a calm environment so that they fall easier to sleep, so to speak. I don't know the evidence on this though, but this is part of why it's not only, it's also because of cognitive loading, but it's all when you're doing the induction, but this is also part of why I think why our anesthesiology colleagues are encourage us to keep quiet during the intubation phase. What I do know though is that with side effects, this helps for ketamine, especially if it's in a calm room. For sedations, especially, they will not get in. They will have a lower risk of getting the bad psychological effects when you go into what you call the K-hole. Then you have the thing about pushing the dose, giving a spike dose instead of like doing incremental doses or even an infusion. So a push dose will go faster. It will be a bit more unpredictable because they will go up and then they'll go down and they will have some kind of stabilization level. Whereas an incremental will be a bit up and then a bit up and then a bit up until you achieve the effect, and ultimately an infusion is just going slowly up until you. So the infusion is usually, especially if you have a drug with a low half-life, the best way to go, but that's usually not achievable in the emergency department, especially not with RSI. So the next best thing in many cases is the incremental way of doing it. Maybe doing a bit of a push dose at first if you have a full dose, then maybe doing 40% in the beginning, and then doing incremental steps of 20% of the full dose, something like that. These are just rule of thumbs, but just to get the picture of how you can dose these. Because push dosing goes faster, but you will achieve faster effect, but you also achieve higher risk of side effects, and that includes hypotension and so on. And when I say push dose, is that you push the full dose or push a large dose in very, very quickly. Yeah. Then it's important to know that high BMI may play in here. If you have really large patients, then you might go by ideal weight rather than the actual weight, depending on what kind of drug you have. If you have lipophilic drugs like propofol, then you might dose according to ideal. And if you have water soluble, then it depends, right? Some of the water soluble things are muscle relaxants. So that's where Then you have dose reduction with hop killers. We've already gone through that a lot. This is especially, and how much you have to reduce is debated, but Scott Weingart says a lot, and other guidelines would say maybe half or 20% or 25%, whereas Scott Weingart maybe in some of his lectures say 10% of the full induction dose, usually full induction dose. Depends. A way to go around that would be to do incremental steps until you achieve the effect. As long as you don't, as long as you know the half-life of the drug, so that you don't chase your own tail, making the patient get almost off the drug before you give the next dose. Okay. All patients with drop blood pressure, I've already been around that. That is because, well, vasodilation for propofol and adrenergic drive for all induction agents will be lost. And if all of the blood pressure is hanging on that, then they will lose blood pressure. Then it's important to know the half-lives and the range of the half-lives. To know when are you going to give the next dose if you do incrementals, and especially during sedations, this is important, and also the time to effects, to know when to give more and what to expect. And yeah, as I alluded to, higher doses, if you want to dose something, then you can do a higher dose, but you can also, if you do it in a push dose way, then you will also get effects faster and even more intensely. So you can achieve effects in different ways, either with higher doses or pushing doses. And yeah, then it's important to know that you have to flush with a lot of sodium chloride when you give the drug, so that there's not any more drugs in the catheters, in the venous catheters, so that, because then there's a risk for, like, there might be a little bit of muscle relaxant left, and then that will be pushed the next time you need to push anything, and then suddenly you don't want, like, if they want the patient to be awake, and suddenly they're relaxed, and so make sure that you're pushing with maybe 10, 15, maybe even 20 sodium chloride every time you give these drugs. And the sequence of drug giving I showed in the last slide is usually painkiller first, then induction agent, then muscle relaxant when you do the RSI. Okay, so let's talk about muscle relaxants. You have two of them. You have rocuronium, Esmeron, it's called here in Sweden, and soxamethonium, which is called silosurin, siloquine here in Sweden. And there's a few differences between them. The main thing is that this has a longer effect. This has a shorter effect. The time of onset is faster with the Sox. It's a bit slower, but usually it's not much slower. There's no feedback with the rocuronium because you don't twitch. You have to make sure that they're actually relaxed by visualization and by touching the patient and so on. Here they will have a twitch, They will like have a small myoclonus, and then you know they're relaxed after that. The thing is, there's no real contraindications for the rocuronium, but there are for this. There's a long list of pretty rare conditions, but especially hyperkalemia is important. That's why a lot of anesthesiologists want potassium when you have to do a sedation, if they need to give succinylcholine. For normal, as a rule of thumb, for any patients, usually it will only increase the potassium by 0.5. But if you have a patient that has been immobilized for a long time, especially in the ICU setting, but also if they're coming from home and they've been immobilized, like a paraplegic who don't use their legs, then you can have an increase of potassium as much as 4 or 5, because those muscles suddenly are giving off a lot of potassium, and when they twitch, and that can be devastating. So that's you can look at the list of rare conditions yourself, but that is one of the reasons. One of the main reasons why probably in emergency situations we shouldn't use this. The people who likes socks is usually because of this fast retirement, because you have a feedback. But I guess most of the people I talk with about this use rocuronium. And there's a lot of debate in the FOAMIT community about this. Ruben Sterry loves rocuronium, and usually has this rocuronium rocks, succinylcholine socks kind of way. So I have no part in this game, but these are the arguments. Here's the dosing, and in the rule of thumb, like with all of these dosing things, it's important to just know one kind of dose and make it simple, because in the bind it's hard to remember these things. So 100 milligrams are usually a good dose for these agents. And it's also important to like kind of visually know what kind of syringe they're in, because if they're suddenly in a wrong syringe, then you know, oh, the dose is really high now. So this is usually in a 5 milliliter syringe, marked as well, and this is in a 2 milliliter syringe. And as I said, Ruben Sterry usually opts for this, and I think a lot of the community are going with him with that in emergency situations. Okay, then we have ketamine as an induction agent. So ketamine, or S-ketamine, depending on what kind of drug you're using. Just remember to dose appropriately. You can use rocks or socks, doesn't matter. There's no need for painkillers with ketamine, because it's a painkiller in itself. The other thing about ketamine is that you can, like, it's incredibly, like, pre-hospital, the evidence from pre-hospital setting is that it's really, really, really safe drug. You can overdose it massively, and people won't have problems with it. Of course, you can. A lot of our colleagues do say that you can lose the airway with a high dose of ketamine, but the thing about ketamine is that you actually don't lose the airway. You have open eyes when you're doing the induction. The patient's eye they're dissociated. They're not like sleeping, but they're kind of, the brain is like the NMDA receptors are in some way doing so that they don't remember anything and they don't feel any pain, and they're like in a trance-like state. So it's a bit weird to see ketamine induction and to like operate on someone who's has open eyes, but it's really safe for that reason, because they do maintain a lot of their reflexes. Don't rely on it though, but they do in many most instances keep their reflexes, and they can usually breathe as well. Okay, for this you probably want to use some kind of anticholinergic though before, and have suction ready, because they do have a lot of hyposalivation, and you will usually get a lot of nausea and vomiting, especially for sedations. This is important. And you can use midazolam for that if they have a problem with psychoperceptual problems. Okay, so just a few tips with this drug. There's been a long debate on whether it increases intracranial pressure, and it does in a patient who is not highly adrenergic. It will probably increase the blood pressure a little bit, and there's an argument, a mechanical argument for this might be increasing the intracranial pressure as well. Therefore, we shouldn't use it in brain injury patients, but or brain bleeds. But usually it's exactly in those situations that you maybe want to use it because there's a hypotension risk and so on. You don't want to have a traumatic brain bleed with a map of 65. You wanted a map of around 80 or above, and maybe a systolic of 120, and it's hard in a trauma situation to get that. So that's why ketamine is usually in trauma situations a really good drug, and you should not use it. You should use it, I'm saying. And the argument of intracranial hypertension is very much debunked. Then, as I said, use a quiet room if you use it for sedation because you need to reduce the anxiety in the patients. They will usually their psychoperceptual symptoms are colored by what is happening just before. So a lot of noise, a lot of ambient light, and so on, and harsh lighting and shouting and so on will give more psychoperceptual problems. Have suction ready. It's good for DSI, as I said, and hypotension. Again, doses are good. Like 100 milligrams of ketamine is usually something that you can always remember. 100 of rock, 100 of socks. 100 of rock and 100 of ketamine. That's if you're in the middle of nowhere, you can't remember any of what I've been talking about, then use that, and then you can probably get 2 in. And then in esketamine, you have to do the half dose because that's double potency. The syringes for this, for IV would be 10 milliliter syringes because the concentration is like this. And then for IM, you have a higher concentration dose. You usually use a 5 milliliter. And this is something that might be obvious as well, but for IV, the reason why we use a smaller, for IM, the reason why you use a more concentrated concentration of the drug is that you don't want to flush a lot of fluid into a patient's thigh that hurts, and it's hard as well. So you want smaller doses. You want smaller amounts of fluid. That's why you want higher concentrations with the IM. It's the same with anaphylaxis. Okay. So the ketamine brain continuum is, if this is from Ruben Strayer. In general, if you give 10 milligrams, then it's analgesic. If you give around 10 to 30, then it's still analgesic. A lot of patients will, for pain management, need around this recreational area. But sometimes if you give it in a slow infusion and not a push dose, and if you give it in a quiet environment, usually you won't get into these problems. But sometimes you will. And then that's what you call the K-hole, the partially dissociated patient here, where it's where they are in a bad way. And you can do different things there if you do end up in the K-hole, because this is good, this is good, this is not good in the K-hole. So you want to either you can push them all the way through to a dissociative dose, and then you'll just sleep, and then they'll come out of it. And sometimes when they come out of it, usually it's when they come out of it that they might get into the K-hole. And if they come out of it and end up in the K-hole, then you can again do 2 things. Whether if you can either push a drug a bit more, so you give it another try, so to speak, or you can go down and give them midazolam instead here for anxiolytica. The thing is with ketamine that if you give a higher dose, usually you won't get a bigger effect. Again, that's the truth with modification, but Ruben Strayer will usually say that you won't get a bigger effect. You'll just get the patient to sleep for longer. You'll get longer duration of the drug. So you have like these 3 doses of pain and recreational dosing. You have your dissociative dosing for inductions, and then you have your K-hole, which you don't want, where it's uncomfortable for the patient. Here the dosing for the ketamine. Remember, you can half these doses for S-ketamine. And for the pain, you usually use an infusion of 0.1 to 0.4 milligrams per kilo. I use a calm room. This is for more like sedation and pains. You usually call these doses sub-dissociatives. Okay, for sedation, you have these doses. For inductions, you have these doses, and you can do it in incremental steps with 40 milligrams per minute until effect, if you want to do the incremental way. And remember always to use the maintenance dose. There was a study on whether we from the emergency departments that came out last year about how many are awake but still intubated and relaxed in American emergency departments. It was a scaringly high number. So always remember the maintenance dose of this. Okay. Then you have propofol. Propofol, or the milk of angels, or what you would call it, is white. You can always see it's propofol. It's like diazepam is also white, and midazolam I think is white as well. So there's a few drugs that are milky white, and this is one of them. You can use Rogov-Sux. The painkiller that you will use is either fentanyl or fentanyl usually, and it's important that you have phenylephrine almost always drawn up because this will vasodilate, and it might vasodilate and tank the blood pressure because of adrenaline being shut off. Phenylephrine will work on the vasodilation part because of the alpha effect, but not as much on the other parts. So you might need other vasopressors as well. Some people, especially when you're working in the theater world, will use ephedrine. Ephedrine is good if the patient is not already high on adrenaline, because that that kicks on the adrenaline system. But if the patient is already in high adrenaline mode, then you need to use phenylephrine instead, because then you cannot activate it anymore than it is already activated. So that won't usually work. So phenylephrine is the one they use in RSI in general. Yeah. And premedication, of course, resuscitate before you intubate. All right, so for propofol especially, it's really important to give the sparing agents. Give muscle relaxants, give fentanyl. You dose reduce around 25 to 50% in hop killers, and you usually do it in incremental steps, maybe with a bit higher push dose to begin with, but you don't want them to go all the way down into operation theater induction mode, because then you will kill them. And that's why Weingart and Cliff Reed calls someone who gives full dose propofol in an RSI moment, they call them propofol assassins. Okay, so you give these increments until you get the effect that you want, and you can check out the effect that you want by calling the patient, hey, are you awake? Or pain stimulating, or activating the ciliary or corneal reflexes. There are different ways of doing this, but when they don't have these and they're relaxed, then you can begin intubation. What I didn't say with ketamine is that Ruben Strayer usually, if you use the combination ketamine and rocuronium, he encourages us to begin to go into the patient's mouth all from the beginning before they're relaxed, so that when they are totally relaxed, you're already in the vallecula. You can hear more about that in his smack talk, leisurely laryngoscopy. Okay. The syringe here is usually 20 milliliters, 10 milligram per milliliter is the concentration. And here are the doses for propofol. So again, propofol is not a painkiller. You have to give opioids. Sedation doses are like 0.5 to 1, and your induction is usually 2 milligrams. And you can give increments of first 40 maybe, and then give 20 to 40 then thereafter. For RSI, again, for hop killer moments, you'll give half that dose. So this is the full dose. This is the 50% lower, maybe even lower than that. But in general, you just you just pull up the drug in a syringe, and then you mark it, and then you can give 40 milligrams untold effect, and you just have to keep an eye on whether when you have reached this point, if they're still not dissociated, then probably you be a bit more careful, or yeah, you have to do what you have to do with that low sedation, that level of induction, so that the blood pressure doesn't tank. Okay. The thing with propofol is that it's really fast in, fast out. It has a quick onset and a long duration. So that's why it's one of the preferred drugs for this. Then you have for fentanyl. Fentanyl has different dosings, but in these situations, usually you'll use 10 micrograms per kilo in a 5 milliliter syringe with this concentration of the drug. The onset is quite fast, and the duration is dose dependent, but with these doses, it's usually for a couple of hours that it will last. For alfentanil, it's as we say here, this is a bit different to dose, but usually you'll dose it around 0.5 to 1.5 milligrams. And the onset is also dose dependent here, but usually you'll give almost a fixed dose with this, and with fentanyl you also almost always give a fixed dose, so you don't have to calculate that too much, because the effect here is a bit harder to see. Then I just wanted to give a quick side note about this kind of medication, because now that we are talking about fentanyl, and I have an audience of emergency physicians, and sedating, painkillers for children is really a topic that is hard, and it's hard in the situations because small children are screaming and you want something fast. And a lot of times in our hospital, even though we don't see children, there's a lot of children coming in through the triage because they're screaming and the parents just didn't know what to do and come to the closest hospital. And then you kind of need to know how to do this, pain manage them. So a good way of doing this is by doing this kind of intranasal. This is a syringe, just a 3 milliliter syringe, this one, but you can use different ones. And this is just a nose, which will be put into the nose, and then you'll spray this into the nose of the patient. And the dosing you can find in the Copy app. And I'll just go through quickly. This next slide is in Danish, but I hope you'll bear with me in this. So intranasal fentanyl magic it's usually for painful procedures in children that we use it, and before you have a IV on the patient. You dose it with 2 micrograms per kilo for both adults and children. And the side effects are usually you can have respiratory depression, but then you have naloxone close by. And you can use IM naloxone. You just have to double the dose if you need to, or you can use intranasal naloxone, so you don't have to use the IV in the kit if you don't need to. You have to monitor the patient, of course, especially with saturation and respiratory frequency. If they're awake still, then you don't probably have to monitor them at all. But as long as they're a bit sleeping, then you'll monitor them. So there are some tips on how to give it, and you give it in the dose around the higher dose range, maybe 2 micrograms per kilo. And there's like some dead space in the syringe, so you'll usually have to drop 0.1 milliliters more than you expected, so that the dead space will be gone. Because when you spray it, then there's usually a little bit left. So the first time you draw it up, then you have to draw a little bit more up. So, and because this is important, like 0.1 milliliters doesn't sound like much, but for small children with small doses, then that is important. Okay. So also we want to, here again, like with our IM medication, you want to use a low dose, a high concentration, low fluid amount. So high concentration, so that you don't have to push too much fluid into the child's nose. if you want to decently aerosolize the medication, then you maximally give 0.3 to 0.5 milliliters at a time, and then you have to give more doses instead of giving the entire dose at once, because then you won't aerosolize it in a good way. Make sure that the snotty nose is cleaned a little bit before. Just blow the nose, and use the nose, the nostril that is most open. The peak onset, the onset is 5 minutes, and the peak onset is like around 7 to 10 minutes. And here's an example of how you calculate. So for 44 kilo child, you'll use 2 micrograms per kilo. That's 88 micrograms, and you'll just round it off to around 90. So then the concentration is 50 milligrams per milliliter. So you'll divide 90 in 15. That will be 1.8 milliliters. Then you will add 0.1 for the dead space for the first shot, and then this 1.9 you will divide that by the 0.3 to 0.5. That would be maybe 5 doses, so that you will maximally give 0.5 milliliters per dose. Exact. And then you will have you'll achieve it. You can alter which nostril you're using. So you can, if the higher dose is a bigger child, then you can alter the dosing. So first in the left and then in the right nostril. So the source for this, for these tips, I forget, but I have it on the blog on fentanyl intranasally, and then you can find the source. Okay, and the last thing we were talking about propofol is the phenylephrine, and usually you'll give 0.05 to 0.2 milligrams until you achieve the effect. The problem is also, like, this is a really alpha. This is like alpha vasopressor, and there's a risk when you do squeeze the vessels that the heart has to work against a much higher afterload, and so just keep that in mind when you're choosing your agents. Choosing propofol means that you probably will have to give phenylephrine, means that there will be a higher afterload and so on. So this is part of why, of course, this is the decision of the anesthesiologist mainly, but as the team leader and we have the overview, we want to be able to participate in this discussion and what kinds of things that weigh in and weigh out, weigh in, and what kind of harms and benefits there are of each choice. Okay, let's just quickly say something about medications with vasopressors or rescue drugs. So in general, vasopressors are something that we don't use in emergency medicine in Scandinavia. We might use a little bit with anaphylaxis. There's we have a pass there, but only intramuscularly, not intravenously. And I just wanted to give you a small physiological, like from an epistemological point of view, this is a physiological argument mostly because there's not a lot of evidence in this area, and because the patients are so variable. And just to hammer that point home, there's this quote a great quote from a Cochrane systematic review that says about vasopressors in hypotensive shock. The quality of evidence differs greatly between several comparisons, but in summary, evidence is insufficient to prove that any of the vasopressors at assessed doses are superior over others in terms of mortality. The choice of the specific vasopressors may therefore be individualized and left to the discretion of the treating physician. Factors such as experience, physiological effects, drug interactions with other therapeutics, availability and cost should be considered. So in general, as Palmcrit Jos Farkas has said about this is, well, you can use what is like from a mechanical perspective might be the best, and then dose it, and then if that doesn't work, then do something else. Because even though the mechanical argument might work in some cases, patients are too variable and the evidence really isn't there. So you have to do this, what Scott Wenger called OODA looping. You have to do one thing and see if it has an effect, monitor it, and if it doesn't have the effect, then you have to do something else. And when you do things like that, then oftentimes it's if the situation allows it, it's better to do a bigger stimuli so that you give a bigger effect, so that you know whether it works or not, than doing small increments where the feedback might be lost in the sea of noise to signal. So yeah. Okay. So here we have a crash course in vaso-active agents. I'm again no expert on this. We do use it sometimes in our departments, not mainly by me, but in our intermediate departments, EMA. So we do have some exposure to this, and in general you have your alpha 1 drugs, or your receptor. Most of the vasoactive drugs go on these kind of receptors. There are some exceptions, like let's see, like milrinone and like vasopressin and dopamine those have their own kind of receptors. But in general, you have the alpha receptors. And if you activate those, they will vasoconstrict. These are agents like pure alpha agents is usually where you have phenylephrine. I don't think it's here, but phenylephrine is a, yeah, here it is, total alpha. That's a pure vasoconstrictor in theory. All of this is in theory. That doesn't mean that it works like that in the sick patient that is an individual and has a pathology that might fuck this up. And might also have other interactions with other medications and so forth. So this is just a priori best estimated guess. The beta receptor is a vaso and bronchodilator, and we know this, the bronchodilation part we at least know from salbutamol when we have a asthma patient or a COPD patient. And then you have your beta 1, which is on the heart, and you have chronotropic effects, making the heart beat faster. But you also have inotropy, making the heart beat harder, so to speak. And then there's a variable, well, the selectiveness, whether or not they're selective towards which beta receptor they're selective to, and so on and so forth. It depends on sometimes the dosing. I know adrenaline has different effects depending on whether it's low dose or high dose. So there's a lot of complexity to these things. But in general, because of the vasoconstrictive vasodilation nature, they have been, you can put your vasoactive agents into groups of vasoconstrictors, vasodilators, and then you can ask whether or not they have an inotropic effect. And therefore you have what you call pure vasopressors that are usually pure alpha. These are your phenylephrine or vasopressin. These will increase your vascular resistance and are usually, like, they will increase your afterload. These are used mainly, well, phenylephrine is usually mainly used with propofol induction. Vasopressin can be used with noradrenaline, especially sometimes, to give a little bit more of vasoconstriction. And you have your inor dilators, and the inor dilators is the drugs that fit down here. They have an inotropic effect. That's why that's the ino part. But then they dilate. So these are usually especially it's isoprenaline. Isoprenaline is really a lot of beta, and that is what we use for bradycardia, because it kicks the heart. You might notice that epinephrine is down here, and it has a lot of beta as well. So these two are usually really closely related, depending on the dose of the adrenaline. But if you don't have isoprenaline around and you have a bradycardic patient, then adrenaline is a good choice, a good second choice, because isoprenoline is usually like, this is adrenaline on steroids. Sometimes they say that. Then you have your other drugs, your butamine and milrinone. And when do we want like some effect on the heart, but we want reduced afterload? Well, in your hypotensive cardiogenic shock patient, where you want to kick the heart a bit, and you want to dilate the vessels so that you don't have too much to push against. So that's where the butamine and milrinone sometimes are found. Again, this is not necessarily how the real world works, but it's at least in theory, and that's why they often can be found in those kinds of guidelines. And then you have your inopressors. Like, there's both an inotropy and there's also vasoconstriction, and here you find the working horse of emergency medicine, which is noradrenaline and adrenaline, depending on the dose, of course. You also have dopamine, which seems like there's always a drug that is better than dopamine to choose. So it seems like dopamine is falling out of favor, but that is kind of the quick and dirty way of looking at all the the vaso-active drugs. And remember, this is not science. This is a priori best guess from physiology. Doesn't necessarily mean that it works in our patients. So you always have to monitor the effects and see if there's what the feedback is. Also, patients might have multiple drugs on board, maybe beta blockers or so on, so that you don't get all the effect that you actually thought. So it's a dose question, it's an individualized patient question, it's a variability question, it's a complexity question, it's a disease question. So this is really, really complex. And for emergency physicians, we probably need to know isoprenoline, we need to know phenylephrine if we are doing intubation, we need to know noradrenaline, that is probably the most important one, and then along with epinephrine. So therefore, just a little bit more about adrenaline. So I don't know how long I worked before I figured this out. I think this is hard, and I think that's part of why anesthesiologists are a bit on the fence about us giving these drugs in Scandinavia. And I mean, with proper education, I think we could, but in a lot of situations, especially adrenaline, is something that we do sometimes give IV until they come, because that is the thing that is usually a little bit less harmful than doing intubations. And sometimes we need to do this. So just to go through a little bit more about the theory so you know what you're doing. So you have adrenaline or epinephrine, and they usually come in 1 milligrams per milliliter vials, and with 1 milliliter in them. And what you do for anaphylaxis is that you give, for adults, 0.5 milliliters, which is 0.5 milligrams IM as a high dose. And the rule to remember is, like, small children, that's 0.15. Then it's 0.3 for the bigger children or small adults, and then it's 0.5 for adults. And you can, of course, do this. You can give that more than once. Sometimes you also have to give it in asthma or in other kinds of upper airway obstruction, especially asthma and anaphylaxis, though. Then you can give it IV as well, and actually this is in the ERC guidelines now, that you can so you can do a 1 factor dilution, so you get to 0.1. You do that by taking 1 milliliter of the 1 milligram per milliliter concentration and mixing it up in 9 milliliters of sodium chloride, and you get a 10 milliliter solution with the concentration of 0.1 milligrams per milliliter. This is what you actually find in the crash cart, like the CPR adrenaline, where you give it IV and give a bit higher doses. The reason why we give it a bit more, not higher doses, but higher fluid amounts. The reason why is when you push doses into the IV, you want you don't want a high concentration just to that can sit in the tubing and then stay there. You want to be able to even if you flush with a little small amounts, you actually give a lot of drug. Okay. All right. So that's the and in the cardiac arrest, of course, you do give 1 milligram, but you just give 10 milliliters and not 1 milliliter. So just so you know because this confused me for a long time. So I'm sure some of you might be confused by it as well. Then you can, this dose here, you can dilute that once more. So you take this concentration here that you just made, and then you take 1 milliliter of that concentration, and then you dilute it once more in 9 milliliters of of sodium chloride, and then you get what you in Swedish call a dubbelspät, like a double diluted dose. This is a single diluted, this is a double diluted dose. And with that, you can just give 2 to 5 milliliters, which would be 20 to 50 micrograms every 1 to 2 minutes until you get the effect on the blood pressure. You might give it even faster. If you want even more of this, you can in 100 milliliters of sodium chloride or in 100 milliliters of glucose, you can just push that in 1 milligrams per milliliter into that, and you get a dubbelspät, a double diluted dose as well. If you want, because then you'll have 100 milliliters and not just 10 milliliters of it. You can also do what you call a dirty epitrip, and you can check out Salim Resay's YouTube channel for how to mix this and how to dose it and how to use it as a temporary measure until you can make your noradrenaline infusion ready in your septic patients, for instance. Okay, so that's where you just take 1 milligram per milliliter, and then this would be a triple dilution. Just push it into that, and you just titrate it until you have the effect you want. Okay, and that's the dirty epitrip, usually used for septic patients. Okay, and it is important, especially when you have the adrenaline, it's important to know that, well, there will be a lactate increase with adrenaline when adrenaline is being used. This has nothing to do with anything else than the physiology of lactate. And if you want to know more about the physiology of lactate, as it is important to the emergency physician, then check out Cliff Reed's YouTube channel, where he goes through an amazing 10-minute lecture about this. And why lactate shouldn't always be a problem or a red flag. Okay. Noradrenaline. Noradrenaline is like everything else, vaso-active agents. It's kind of, well, not always an exact science, but in general you can start off with giving 0.02 micrograms per kilo per minute in an infusion, and then you can maximally give 10 times that. I say max in quotes here because sometimes you will get more, but usually you will combine this drug with something else, because, well, if you go up to this dose, well, maybe it doesn't work as well as you should, and then you will combine it with, for instance, vasopressin. Okay, always look for feedback when you do give these doses, and usually this can actually be given. There's a lot of, like, earlier there was a mantra that you have to give vasoactive agents in a CVK, but you can give it in a PVK, like a peripheral venous catheter, an IV, as a temporary measure until you can get a CVK. There's some evidence that can be found on both First 10 EM and also on Salim Resay's homepage and YouTube channel. And there is also from the Rebellion, I'm also almost saying festival, but the conference that Salim Resay put up and his team. There's a great walkthrough as well about vasopressors there. Okay, so let's if we do an induction in a 70-kilo patient, let's say the patient has a dynamic airway, but our normotensive, maybe it's a burn victim patient. We do a propofol induction, and then we'll not give any premedication right now because they're all right. We might give some fluids according to
usually burn victims, but not overdose the fluids. The Parkland formula, that's the name, yeah, the modified Parkland formula you can use there. Then you give a painkiller that might be fentanyl, and you'll give in a 2 milliliter syringe, give the entire dose, which would be 1 milligram. Then you'll induce with 2 milligrams per kilo of 10 milligrams per milliliter in a 20 milliliter syringe, which would be 70 kilos. That's 14, so 140 milligrams divided by 10, and that's 14 milliliters. And if you have a hop killer patient, which this isn't, maybe depends on the pH and so on, but if whether it's a traumatic thing as well, because if it's a traumatic thing, whether it might have occult bleeding, which all burn victims should be assessed for. All burns are traumatic until proven otherwise. Then you can reduce this dose to just 7 milliliters, and then you can give it incrementally for like 20 or 40 milliliters push until effect. And this patient is also a patient that you might want to consider an awake intubation if the skill set is available. But you'll still need to draw up this for when the tube is in. Okay. Then muscle relaxants, you'll just give 100 milligrams of, you can use socks here, or you can use rock. I just use socks here so that you see that you can use it here as well. Just make sure the potassium is all right. And you just give the entire syringe, which would be 100 milligrams. Okay, let's try an S-ketamine. That means the double potency drug in a traumatic, hypoxemic, hypotensive patient. So we will, of course, premedicate with blood products and stop the bleeding and so on, all that we learn in ATLS or European Trauma Course, ETC. You'll not give painkillers for this purpose, for the induction, but you might give painkillers for other reasons. But the ketamine will at least help a lot with this pain management when you give it. The induction, you will give 0.5 to 1 milligram per kilo, which would be 70 milligrams in this patient. And for S-ketamine, you'll have 5 milligrams per milliliter. That'll be 14 milliliters, and ketamine is always drawn up in 10 milliliter syringes. And then you'll give incremental doses. Every time you give or your assistant give the dose, then they will say how much they've given. So it's like a callback fashion. If you don't have an IV, you have to give it intramuscularly. Then you have to give like much higher doses, and you'll give, in this case, maybe times 5, so that's 350 milligrams. Divided by 50 milligrams per milliliter, that's a different concentration than this one, right? You'll just give 7 milliliters of drug in a 10 milliliter syringe again. Okay, so now that we talked about vaso-active drugs, and we have done the entire plan, the positioning of the patient, the pre-oxygenation, and we've done all the preparation. Now are the minutes that we told the team leader that this would take have gone, and we're now ready to induce the patient with the drugs that we drew up, and we're ready to put the tube in the vocal in between the vocal cords, so that the patient can get an airway back. So just as I described during the medication theoretical walkthrough, you're now standing at the patient's bedside, behind the patient's head. You've pre-oxygenated them, and you give the go signal for your assistant to give the drugs. The assistant will give the drugs one by one. First the painkiller if you've chosen propofol, then the induction agent, and then the muscle relaxant. Depending on what kind of muscle relaxant you've chosen, you will, and what kind of philosophy about this you use, you will either wait until the patient is totally relaxed until you begin, or you will do it a bit faster than that, if you follow what Ruben Strayer usually preaches. So
And now everything slows down. The intubation itself is a lot about microskills. And there's a concept of EVLI, which George Kovac has coined. And he's made a few videos on this, all of them available on YouTube. And I really encourage you to, if you haven't watched those, for this specific topic, this is really gold. This talks to a lot of the philosophy of Scott Weingart as well. He's also done a lot on this, on the motor skills, visualization drills, and in this moment where it's truly first pass success, that is the success criteria, and you not having anyone becoming, you not having the patient becoming hypoxic or hypotensive. It's all about speed, and there's this, theme, or there's this mantra that Scott Weingart usually uses, which is slow is smooth, smooth is fast. So this is not a fast thing. This is a you go through all the increments that you need to go through in order to get the tube in. This is a precision thing as well, so you don't hold the laryngoscope on the shaft. You hold it down where the way down below, sometimes going all the way into the if the laryngoscope is an L shape, then it's at the angle you hold it oftentimes. So you hold your laryngoscope in your left hand, and with what you call a feather grip, not what Ruben Strayer calls a death grip. Okay, but I'm getting ahead of myself. So that was just, all these micro skills are really important. So, and we'll go through these micro skills, or micro pictures in your head, visualization drills that you need to go through to be able to be good at this. And then you have to practice, deliberate practice. And that's why I'm trying to slow down here now as well, so that you can get the feel of it. So first of all, you will open the patient's mouth. When you're opening the mouth, you can either scissor it open with your right hand, or you can pull a finger into the upper part of the patient's mouth and pull back, so that you can open the mouth like that. There are different ways of doing this. Then you are, by your assistant, handed the laryngoscope in your left hand, and you're holding it with a feather grip. And the first thing you try to see in this epiglottoscopy is the uvula. So you open the mouth and you try to find the uvula. But even before you enter the mouth, sometimes you can see it if they have a low Mallampati score. But if they have a high Mallampati score, you need to go in through the mouth before you can find the uvula. And the uvula is important because it will point towards the epiglottis. So try to close your eyes now and imagine that you are, with your laryngoscope, going into the right side of the patient's mouth, and you're moving gently the tongue to the left, and then you're slowly but surely advancing the laryngoscope through along the tongue's surface, millimeter by millimeter. You're seeing the uvula, and as you advance, you are also now seeing the epiglottis. When you see the epiglottis, then you advance a bit further and you go into the vallecula. If you're really spot on, then it won't take a lot of strength to pull in the direction of the handle, making sure that you don't tilt the laryngoscope so that it hits the patient's teeth, but you pull in the direction of the laryngoscope, usually usually you can look towards, there's a straight line pointing up to usually the clock right in front of you, which is the direction that you have to pull. When you are in the right spot in the vallecula, you will oftentimes have a special feel for it. If you lift too early, then you won't get this feeling, and if you lift too late, you won't get this feeling either. This is a question of millimeters, so please watch the Kovac video, EVLI video, to make sure that you understand this concept. You also need to be center on. You don't have to, so that when you go into the vallecula, you're on center. That will also help you to use minimal force during the opening of the airway when you're pulling. Okay. Then you do the laryngoscopy, where you're visualizing the vocal cords. And now you have a view of the vocal cords, and once you have a view of the vocal cords, you will not take your eyes off it at any point until there's a cuffed tube there. That means that your assistant now needs to get the instruction to hand you the intubation, the tube, and you've already said whether or not you want a bushi or a stylet. If you want a bushi, they'll hand you the bushi first, and they will usually hold the top of the bushi for you so it doesn't wobble around. And you'll see the bushi go in through the vocal cords. And as they enter through the vocal cords, you'll tell your assistant to load the bushi so that the tube can go into the vocal cords. If there's a problem with either the bushi or the tube going into the vocal cords, then you will twist it, usually counterclockwise, depending on whether you are using video or direct laryngoscopy. Check the video from George Kovac for details on this. And when it goes in, you will tell your assistant to cuff the airway so that you see that the cuff is being blown up. You still haven't taken your eyesight away from the hole, like the vocal cords, and you will only take it away once your assistant says that that they have cuffed, and yet that you can be sure that it is cuffed, and that your assistant have put on a back valve mask, and yet you even can measure end-tidal CO2 here. At this point, you can pull out your laryngoscope, and you can, but with your dominant hand, your right hand. Sorry, not your dominant hand. It will always be your right hand. With your right hand, you will still hold the tube. You will not release your grip on the tube until it is secure. Now you're moving the laryngoscope out of the mouth slowly, and so that you don't hit the teeth on your way out. And you will tell your assistant to secure the airway. Secure the tube with tape. And you will back valve mask the patient. And at this point, you will also monitor and check that the end-tidal CO2 is good. You'll check that there's chest rise with the stethoscope. Your assistant will listen to the chest. And you will check that the patient isn't hemodynamically compromised or severely hypoxic. And you're done. Now, kind of like the way I just went through this is how you want to visualize it, and you can put layer upon layer upon layer on it. You can imagine that you're in your emergency room. You can imagine that you are like, there's a lot, like if you look at Mike Loria's paper on the Beat the Stress Fool paper that I showed you earlier, if you use the if you check that out, then he will go through how to optimize your visualization techniques. You can use this for anything, CPR situations and so on, but this is a really good technique. Now I just want to go through a few details about when you're using video laryngoscopy. When you're using video laryngoscopy, which I encourage you to do, especially if you're an emergency physician in these situations, because we want to be as secure as we can, then you will not enter the mouth in the right side. You will just enter straight on. And you will, when you have seen, much like the fiber optics, flexible fiber optics going into the nose, once you see the blade tip passing into the mouth, you will now look at the screen, and it's not the hole in the, it's not the physical hole in the patient's mouth that the vocal cords that you're going to look at. You're going to look at the screen, and you will not take your eyes off the screen at any point until the tube is cuffed. If you're using a hyperangulated blade, what sometimes is called a D blade in certain manufacturers, you will have a specific stylet instead of a bushi. You will have a special made metal stylet, and this you have to make sure that while you're entering the vocal cords, that the stylet is not leading, but there's a tubing, like there's plastic in the front end, so that it doesn't damage anything going down. You will then push up with your thumb the stylet, and so that when you're in the vocal cords, you'll push it up with your thumb and make your assistant push the last bit. And also, often with the hyperangulated blade, one of the problems is that you sometimes go too far down. The view on the video is too good, so to speak. You have too good a view. You go too close to the vocal cords, which would make you see a little white ring called the it's called the Kovac sign, according to Weingart. And this is a sign that you need to pull a bit back. So that's some of the main problems that you might find during your intubation with a video laryngoscope. And you find out this by, if you didn't pull back a little bit, then you wouldn't be able to get the tube into the vocal cords. It'll go into the esophagus all the time. And when we're talking about the trouble that there is, how can you optimize the situation? So this is the modified Cormack Lehane grading, and this is like the view that you're seeing, a grade 1 view. This is just put the tube in. If you have a grade 4 view, you can't see anything, and you shouldn't try to intubate. Anything in between, you will try to optimize, and you also try to optimize the grade 4 view, but it's hard. And Scott Weingart has this kata. A kata is like psychomotor, like really deeply learned skills that for each karate move done in martial arts, then there's a contra move, and the contra moves, as I understand, are called katas. These are the ones that you practice. So when your patient when your opponent goes kick A, then you'll parry with a parry Y or something like that. So you kind of know, it's like this dance kind of, and it is also like trying to drill down the motor skills of this, like trying to close your eyes, visualize the scenario, and try to practice what you're actually doing, and check out Scott Weingart's videos for even better instructions on this. So he has this neck, head, hands, scoop, pull back. So when you're into trouble and you want to improve your view, then first of all you do neck. Neck is what you call bimanual laryngoscopy, I think it's called. It's you take your so when you're in when you're doing laryngoscopy on the patient, then you take your and you don't have a good view, then you take your right hand and you push on the thyroid cartilage, the Adam's apple cartilage, and then you can you just push dorsally, and then you'll be able to get the vocal cords into view a lot of the times. It's really an amazing technique, and this should not be confused with the technique called burp, which is upwards pressure. I can't remember. I don't use burp, so I can't remember the acronym. But it's a similar, but not quite the same kind of technique where you push inwards and upwards, and that's the burp. It stands for like something like inwards, upwards pressure. And it's definitely not the same as cricoid pressure. Cricoid pressure is pressure that would theoretically reduce the risk of aspiration, but it's really in the last couple of years it's become really controversial. And if you want to see just one really good argument about this, just see John Hines' Cricle old YouTube video. You won't regret it. It's really good. So you'll do bimanual laryngoscopy here, where you and once you have the view that you want, then you make your assistant take over your grip. So you tell your assistant push here, and then they'll do that, and then they'll keep pushing there. Head is that you can, with your dominant hand, if that doesn't work, you can with your dominant hand lift the patient's head a bit so that you're getting into this flextension position, and because sometimes they will lose the position and during whatever position during all the chaos, and even though you try to position them, and then you might get an even better view if you take the head and push it a bit up. Hands is that you try to grip the handle of the laryngoscope with your other hand. So while you're in the vallecula, you'll grip the hand with your right hand. So you'll grip the handle, and now you will go from the feather grip up to doing holding the shaft. Only now you will hold the shaft, and then you'll pull with both hands. And once you achieve the view that you want, then you make your assistant hold the laryngoscope, or help you hold the laryngoscope. Either that, or usually once you pull with both hands, then you kind of can oftentimes just release with your right hand, and then you can hold it with your left hand. Even though it took two hands to get there, you might be able to hold it just with one hand. The scoop is I actually forget what the scoop is, because I think it's something for special situations, which it's usually not a problem for most of us. But check out Scott Weingart's channel for that.
and his video on this. And then just pull back. Pull back is the thing I just explained to you when you have a video laryngoscopy. Then you have to pull a bit back with your laryngoscope because you're too far in. The view is too good. You have the Kovac sign where you can see a white tracheal ring between the vocal cords. Then you're too far in, and you have to pull back and to be able to pass the tube. Also, part of this is also like the twisting of your tube if you can't get it in. All right, so neck, head, hands, scoop, pull back. That is the Kovac Katta, or what he calls the Kovac Katta. Okay, so this is like in 20 minutes the RSI. Sorry, the getting the tube in once everything is ready. Yeah, please look at the links down here. Okay, so now we'll just look at the vocal cords. And this is from Preperation here. So what the view that you will be seeing is that you have your epiglottis up here. You will have your apneic folds here, and you will have the cartilage here, and then you'll have the vocal cords. And this is where you want to pass the tube into. You don't want to go down here. This is where you have the esophagus. And this is the hole that you always want to keep an eye on. Here's the vallecula, and your laryngoscope will, the point of your laryngoscope will be here. Unless it's a Miller technique. Oh yeah, now I remember the scoop. As I remember, is that you can do with a normal Macintosh laryngoscope, you can use a Miller technique or a children's intubation technique where you try to scoop up the epiglottis. Usually you'll stay here in the vallecula, but you can with a Miller technique, and with children you will usually try to catch the epiglottis and then pull and then pull. So that you can try to like catch the epiglottis as part of the neck, head, hands scoop pull back, but it's a kind of special technique to do, and but that's the entire kata. Okay. Then once everything is all right, and once then sometimes there's a lot of like there's like a release in the room of tension, but this is some of the more dangerous periods during the resus, because everyone's relaxing. But there's still a lot to be done, and you need to monitor the patient that you're not going south. So you need to be monitoring the patient, and maybe really like you need an arterial line for blood pressure. You need to monitor all the other stuff that you've already been monitoring. You need an end-tidal CO2. Like monitor the patient maybe every 5 minutes, something like that to begin with. Maybe even more frequently than that. And then after that, then you'll usually put down an NG tube to deflate the stomach if you need to. You will usually have to use some kind of vasopressors, and you'll also try to then comes all the things about how you set up your ventilation. Right now you're back valve masking the patient, but soon enough you will have to make a machine do that, and look at Scott Weingart's dominating the vent lectures, and then you will be an expert at that as well. Okay, just a few minutes about capnography, because it's not well taught to us in emergency medicine, but it's something that we need to know a little bit about. If you want to have a good lecture on this, the part 3 of the Ruben Strayer PSA trilogy has a good walkthrough on this. And in general, the normal capnograph looks like this. There are different phases, and sometimes there are more than just 4 phases. Sometimes it's parted into a few more. Let's say
around from here and until here, that is the expiration phase, and onwards from here until this begins again, that's the inspiration phase. When you inspire, there's no CO2 going into the detector of end-tidal CO2 or CO2 detector. And then when you begin expiring, then you will first expire from the conducting airways, which would be your trachea, your the proximal parts of the lung tree, where there's not a lot of CO2 or no CO2. Then after a while, you'll begin to empty the lungs, and you will have this steep rise in CO2 until you get to the, I think it's called the alveolar plateau, where the steep rise will be replaced with a slowly but surely rise until you get to this point, which is the end tidal CO2, because this is the end of the expiration where it's maximal. And then you'll go into inspiration, and then you'll move on, and this will continue. If you want to know a bit more about why end-tidal CO2 should not only be used in cardiac arrest situations or in intubation situations, but also be used in back valve masking and other situations, then please check out George Kovac's Super BVM video on YouTube, because there he explains this concept of pulse ox lag, the saturation that we're seeing on the on the pulse ox is delayed around 1 minute compared to what the brain is seeing. So when the patient is when the SAT is 85, then the brain has seen 85 for a minute, and even lower now, because what the brain is seeing has now moved on as well. So and a way to be more direct in our attempt to do what the brain is like, or measure what the brain is seeing, might be capnography. That's the concept of pulse ox lag. Okay, so end-tidal CO2 should be done more. The normal values, as I think I noticed earlier, can be calibrated with an ABG, so that you take the PCO2 and then you kind of calibrate it with your end-tidal CO2, and then when you really need to be in the sweet spot on hyperventilation, when you have a patient with increased intracranial pressure, then you can kind of calibrate your end-tidal CO2 to measure and then you have to recalibrate it once in a while, once in a few minutes, I think. Again, I'm no anesthesiologist, but it's just like the theory of how you could do this. Normal value is 35 to 40 millimeters of mercury, and there's a few concepts that are important. If it's 0, then there's no connection, or you're dead. You can't have just a flat line. Then there's no connection. And that's where you want to pull out or reconsider how your tube is sitting if you have to intubate the patient. You do sometimes see a sudden increase, and this is usually, especially in a CPR scenario, then suddenly you have ROSC. Or you don't really have ROSC, but it's an indication that you might have ROSC because the patient has begun to maybe breathe spontaneously and expire CO2. There's still CO2 capture. There's still some CO2 when you're like have the tube in, but a start, even though they don't have ROSC, but if they suddenly get ROSC or breathe by themselves, then they will have this drive, and then you'll see the rise in CO2. It doesn't mean that they have ROSC, though. You need to check the pulse for that, and then then it's debatable whether it should be a POCUS pulse or it should be a normal like finger pulse. But anyway,
the ROSC is what it is, but it's an indicator of ROSC, and it's been in the RSI guidelines now as well. And if you get a sudden decrease, there are subtleties to this, and please see Ruben Strayer's video on this if you want to go into more details. It's especially important during PSA, because during PSA, before they desaturate, again, this is pulse ox lag. Before they desaturate, they will get a change in their entitled CO2, and that's why you probably during PSA always need to do this, have a entitled CO2 on the patient, so that you can anticipate them desaturating before they actually do it. And again, yeah, this is the gold standard for tube placement. There are other things that the only thing that it can't really show is whether or not you have done a bronchoscopy, if you're intubated in just the one lung, where you have to pull back a bit. But you might be able to do that by measuring the teeth, by how far down it is by the teeth level, and doing stethoscopy. There are other ways, but they're not mainstream yet. Ultrasound to see if the tube is in the trachea, and the good old looking for chest rise, looking for condensation on the tube as well. All right, here's just a few capnographies to be aware of. This was the normal one. And once you understand what each phase means, then you might be able to distinguish what the other ones would mean. In asthma, where you have a slower expiratory phase towards the peak, not a sharper rise like that, but a more slow because of the obstructed airways. Here is if you're hypoventilating, then it's kind of paradoxical. It's not really intuitive until you think about it. But if you're hypoventilating, you'll have higher CO2. That means that you'll get a bit more CO2. On the other hand, if you're hyperventilating, then you'll get less and less CO2. And again, look at Ruben Strayer's video. He has some great nuances on this. And here you have a low level when there is some CO2, but there's not really, the patient isn't breathing on their own. And then suddenly, if they start breathing on their own, then you'll sometimes, it's not a very sensitive marker, but it's a specific marker, and then you'll get this return. If your patient after intubation suddenly crashes, more likely in the ICU, or if the patient is coming in intubated, it's important to always think about this algorithm. Again, I don't receive any money from this book, the RCM, the Weingart book called RCM. But I'll just show you in a little while what it's looked like, and I really like the concept of this book. I think it's the book and the concept that should be widened and used in much of emergency medicine. So there's a mnemonic called DOPES. When you have a intubated patient that you need to know why they're crashing, there's displacement of the tube, there's obstruction of the tube. Displacement would usually be, well, during cardiac arrest, then the tube moves up and down with the compressions, and pre-hospitally usually you don't always see the tube going all the way through the vocal cords, or there are some reason why it's harder because of environmental factors and so on. So you also always need to check that it's not displaced by checking the entitled CO2 and the other signs that we just talked about. It can be obstructed, the tube. There might be pneumothorax. There might be equipment failure. And there might be stacked breaths. Stacked breath is usually when you have an asthmatic patient where you will hyperinflate the lungs, where it can't really escape. And there's something that especially you saw
for a couple of years, or some years ago, I think. It's not seen that much right now, but these differential diagnoses or mnemonics, here it goes into what you have to do. So this is meant for an ICU, but it's kind of the same in the emergency department. Call for help, and if the patient arrests, then you start compressions. The first thing you do is disconnect the patient from the ventilator and allow exhalation. This is for the stacked breaths mainly, but also to see if there's any kind of kinking in the system. Then you'll try to oxygenate the patient, and you'll confirm the intratracheal tube position with the waveform entitled CO2, so that it isn't displaced and not kinked or in any way. Then you'll listen for any leaks. And then we don't pass bronchoscopes in the emergency department, but you'll see if there's any kind of obstruction down there. You might push a bushi down there or something like that to see if there's any kind of obstruction. And then you'll consider doing a re-intubation. You'll use bedside ultrasound to see if there's been a pneumothorax. And then after that, you'll review the list of common causes. And here's the list down here of common causes. There's a few that doesn't go into the DOPES mnemonic. And here's a bit of argumentation why we're doing what we're doing that I just explained. This is the book, the Resuscitation Crisis Manual. Again, I don't receive any money for this. This is just a great book and a great concept that I want to bring up, that I wanted to show you and move forward. So when you have a patient that is intubated, coming in intubated, then you will always assess the A, and part of the A is to assess the patency of the airway, which includes the intubation and the tubing. So you check the inside of the CO2, you check that there's equal breath sounds, that no pneumothorax. You go through DOPES here. So just a reminder that you need to do that with a tube. Okay, that's the end of the advanced airway, and now we'll, in the last part of this series, we'll go through some other concepts, especially tracheostomies and laryngostomies, and what you do when patients with those kind of devices come in. And all right, see you at the part 4.